Okay, so we are live on the YouTube. Good morning. Can you hear me all?
Yes, sir.
Okay. Good morning. Welcome to Saturday Club Baroda meeting. Today we have a very interesting topic, and that is invasive fungal infections in children. And to talk about it, we have a very well-known speaker, Dr. Kamna Gandhi. She had been to Saturday Club many times before also. Just to give her brief introduction, she is a consultant pediatric infectious disease based in Vadodara. She did her MBBS from BJMC Pune and MD from Mumbai. And then she did her fellowship in pediatric infectious disease from Bharati Vidyapith University, Pune. She has special interest in PUO, TB, HIV, immunodeficiency, MDR infections. And she has to her credit some publications, especially case reports of uncommon infections. And she is visiting consultant to KGP Children Hospital and many other children hospital in Vadodara, and a very popular speaker at national and state level. So welcome, Dr. Kamna Gandhi. Over to you. You have about 40 minutes to talk, and then we'll have 10-15 minutes of discussion. Over to you, Dr. Kamna.
Thank you so much. Very good morning to everyone. I'll share my screen. Is my screen visible, sir?
Yes, yes.
Okay. Today I'm going to talk about only invasive fungal infections in children. We have in last 2 decades made a lot of progress in fungal infection diagnosis, prevention, as well as using the antifungal agent in a very effective way. In pediatric age group, we were seeing fungal infection only in the post-chemotherapy patients, but now with the advanced techniques of diagnosis, we are able to diagnose these infections in many other categories of patient. So medical mycology is a very complex subject and was thought to be very boring and not very much happening subject in the infectious diseases. As I said, IFIs, that is invasive fungal infections, were seen in immunocompromised hosts most commonly, but uncommonly are also seen in the patients who have normal immunity. They are deadly, they are rapidly progressing. So the mortality is very high with the fungal infections, invasive fungal infections that observed post-COVID mucormycosis. Everyone knew how badly it hit after the COVID infections, and the diagnosis was delayed and it was widespread and many lives were lost. The high suspicion is very much important for the early detection, and these are culture and serological markers are the diagnostic tools. So in what settings do I see or suspect the fungal infections in pediatric age group? One is a neonate. So candidemia in the neonatal age group is, I think, the fourth most common etiological factor for bacteremia patients who are admitted in the NICU. Children in the PICU who have a long stay, who have multiple invasive monitoring drills, who have received a broad spectrum antibiotic, are the one who get the fungal infections. Children on chemotherapy and... Is my voice echoing, sir?
No.
Children on chemotherapy and stem cell transplant recipients, those who are primary immunodeficiency, secondary immunodeficiency like HIV, and post-solid organ patients. More commonly, we are seeing the cystic fibrosis patient now on prophylaxis, and with all good care, now our cystic fibrosis patients are living longer. And now we can see aspergillosis.
We are able to hear you well.
Okay, sir. We are able to make them survive longer than before, like 10-15 years. And the aspergillosis actually inhabits and colonizes their lungs. And most of the time, they do not have a invasive aspergillosis, but they have an allergic aspergillosis. Also in the chronic infections like tuberculosis, where the cavitatory lesions are there, we are finding that the aspergillus colonizes those cavities and sometimes cause allergic phenomenon, or even sometimes cause an angio-invasive aspergillosis. So these are the settings where we are able to diagnose and pick the infections, the fungal infections, which are the common fungal organisms which are seen. So which are of a clinical relevance are Candida, the most common IFI, which is found in the ICUs, the Aspergillus, Mucor, Cryptococcus, and others which are little less common are Rhizopus, Fusarium, and Histoplasmosis. One more important factor in the settings of the invasive fungal infections is in geographical distribution, because the exposures are also very important. Like we know how Cryptococcus is associated with the pigeon droppings, or the Cryptococcus neoformans, the Cryptococcus gattii is associated with the eucalyptus trees. So we should always ask a travel history also in all these suspected patients to know what kind of a geographical exposure could have happened in the patient. So I'll go to few cases which are I found interesting, and which will give us an insight about some antifungal agents and how they are used. So this was our case which we discharged a few weeks back. The child stayed with us for almost 6 months in the KGP hospital. This was a 17-year-old cachexic adolescent. He was weighing 25 kgs at the time of admission. He presented with fever, weight loss, chronic cough. After admission, he was diagnosed as a disseminated tuberculosis. His gastric lavage came out to be positive, MTB detected, but RIF resistance was not detected. On the very next day, he had an intestinal obstruction and perforation. He was operated, laparotomy, and the ileal resection with jejunostomy was performed. And with jejunostomy in situ, we had to actually go through a very difficult of designing an AKT for him, because his absorptions for AKT, all the 4 oral drugs like isoniazid, rifampicin, pyrazinamide, and ethambutol, were not sure whether they would reach therapeutic levels or not. So we had to construct some second line drugs along with some injectables to with an intent of achieving a higher efficacy AKT for him. He received multiple things happened in his course, that he received intermittent and partial TPN for like quite long time, more than 2.5, 3 months. Multiple courses of higher broad spectrum antibiotics were given. Some were prophylactic, some were presumptive, and some were empirical. There were 2 episodes of spontaneous pneumothorax. We don't know the etiology, but which required a short duration invasive ventilation also. There was a wound dehiscence in the 3rd month with the MDR Klebsiella, which was isolated and treated adequately. So after all this, so many things were happening. After 4 months of ICU stay, child had a persistent fever, and this time the fever was not responding to our antibiotic upgradation, which we are doing according to our protocol. There were a lot of risk factors for fungal infections, like he had a prolonged ICU stay, the central line was in situ, there were prolonged multiple broad spectrum antibiotic courses. It was a GI surgery, which is also a very important risk factor for fungal infections. He received a total parental nutrition also. So considering this risk factor, I started him on an injectable fluconazole empirically. The CT abdomen was done to rule out any intra-abdominal pockets, because he had a recent episode of this Klebsiella pneumoniae wound dehiscence. The pus came positive. So it's always possible, if the infection is not completely eradicated, there would be some deep-seated intra-abdominal collection, which may give rise to fever like this. But as we expected, the blood culture sample grew a Candida growth. So this was a species as a Candida parapsilosis. So few years back in India, or actually the most part of the world, we were seeing the most common Candida species which was responsible for bacteremia was Candida albicans. But nowadays, in past few years, we have seen that non-albicans species have taken over, and the albicans is going down. So Candida parapsilosis is the most common next to the albicans. We could see the sensitivity here. It was sensitive to fluconazole. So we were already given fluconazole to this child. Central line we removed as a protocol in any fungal infection, and for that matter any bacteremia, whatever invasive lines are there, we need to remove them, because the chance of biofilm formation and your antibiotic may not work if the central line is kept in situ. The IV fluconazole were continued.
ચાલતું લાગે છે, એટલે હું વચ્ચે ઇન્ટરપ્ટ નથી કરતો, કારણ કે બીજા બધાની મૂવમેન્ટ ને બધું તો દેખાય છે.
Sorry sir,
કારણ કે તમે સાંભળ્યું ને એનો અવાજ, તમે YouTube માં ટ્રાય કરો સાહેબ, મેં લિંક મોકલી છે, તમે YouTube પર જુઓ, દેખાય છે.
hello sir. Okay, the central line was removed and IV fluconazole was continued. No clinical response was achieved in terms of fever. The child kept on spiking. The Candida parapsilosis is actually an emerging cause of fungemia, which is associated with biofilm formation. And it is known that the conventional azoles like fluconazole may be ineffective in the 1/3 of the cases. Actually, the fluconazole is a very complex drug which actually requires a therapeutic drug monitoring. And in India, therapeutic drug monitoring for fluconazole is not available. So we shifted empirically this child, because the clinical response was not achieved, to IV amphotericin B. We did a repeat blood culture after 2 weeks. So in any case of candidemia, the duration of antifungal regimen is decided after the bacteremia is cleared up. So we are supposed to do the blood cultures every 3rd or 5th day to know when the bacteremia has cleared, and we continue the antifungal agent 2 weeks after the clearance of bacteremia. So we did a repeat blood culture after 2 weeks, but it was still growing candida. So we kept on doing these cultures every weekly till we found that after 5 weeks of ampho B, the candidemia has been cleared off. The antifungal treatment was stopped 2 weeks after the culture negative report had come. Patient also had a prolonged neutropenia. So we discharged him on a fluconazole prophylaxis to further prevent the situations like this. So what were the learning points in this? That we have to have a high suspicion, as I say, for all the critical and severe infections and all the hospital acquired infection, that we should know that this can happen. If it's in our mind, we are able to detect it earlier. So those who are on a prolonged broad spectrum antibiotics, the candidemia is quite common. Azole and echinocandin sensitivity is important, because if we do not have a sensitivity, most of the time you are not able to figure out why the drug is not working. Are we not able to hit the drug properly? So depending upon the MIC, we will be able to make changes and modifications in our regimen. Early empirical therapy, whenever we have a suspicion, we start therapy and then step down after the culture reports are received. Cultures are only positive in the 50% of the patients. So that is a challenge, and we can say shortcoming for our microbiological diagnosis. But what we can use in these patients is a 1,3-beta-D glucan level. So it is a serological biomarker which is available, and it has a lot of false positive and false negative results. The false positive can come because of even giving an piperacillin tazobactam or any BL-BLI combination to the patient. That will also cause a false positive result. But I think doing more than one test, keeping a higher positive value to be taken in account, will give us a more and more specific information on this. The antifungal prophylaxis is beneficial in certain groups. So there are a lot of studies which says that in the hemopoietic stem cell transplant patient, which has an very high rate of invasive fungal infection, the fungal prophylaxis will reduce the all-cause mortality, even in the high-risk leukemic patients. So I think antifungal prophylaxis is one which is very important in this group of patients. We de-escalate to narrow spectrum antibiotic in ICUs as early as possible after we have received the culture or after the patient has been stabilized. We always de-escalate to the narrow spectrum antibiotic, which will help in reducing the incidence of the IFIs. Going to the next case, this was a 14-year-old girl diagnosed as a severe aplastic anemia. There was no response to horse ATG or cyclosporin, which is the first line of management for aplastic anemia. But she did not respond. So bone marrow transplant was offered to her with a curative intent. She underwent a bone marrow transplant. She was referred to me at day 45 in view of a persistent fever. So what all treatment history happened till day 45 was that she received a conditioning regimen with the rapid ATG, fludarabine, cyclophosphamide, and a total body irradiation. She was also on a GVHD prophylaxis, grafts versus host disease prophylaxis with cyclophosphamide, tacrolimus, and MMF. All this immunosuppression was going on. She was on antiviral and antifungal prophylaxis already. Neutrophil engraftment was achieved on day 18. So this is a normal protocol what they follow for the bone marrow transplant. Because there was no response to the antibiotics which were going according to protocol, they were upgraded. So she was receiving meropenem and teicoplanin, and then was shifted to colicin and TJ cycling. Also, the aspergillus galactomannan was positive, so voriconazole was added. So then that voriconazole, we also added a caspofungin, because in transplant recipients, the protocol of antibiotic upgradation are little aggressive, because we can't afford to any buck to miss, and this is the protocol we upgrade. The CMV PCR, quantitative PCR, was showing a 37,000 copies per ml. Blood culture also showed a growth of Candida tropicalis. So if I take all these factors into consideration and want to find out what is the cause for persistent fever, there are multiple things. There is a CMV which is sitting there. There is a candidemia which is there. There are multi-drug resistant bacteria which have been already detected. So the issues which I found where it was a persistent non-responding fever, on examination, she had a gum hyperplasia and there was a decreased mouth opening. So I don't have a clinical photograph of her, but she was looking very stable, but the face was little edematous. Her oral cavity on examination showed a very poor oral hygiene. There was a mucositis. There were secretions in the floor of the mouth, and few of them were blood tinged. There was a gum hyperplasia. And on a very careful examination, which patient did not notice, or even relatives and nobody noticed, was a very small hard palate blackening and ulceration on the top. So it was just 0.5 centimeter to 1 centimeter in size. And there was a mild squinting of the left eye, which the relative says she never had squint, but this looks like a new development. So with this all features, we decided to go for a neuroimaging with the face. So her blood reports were hemoglobin was 7.3, WBC count was low, 1700, but her ANC was good, 1500. So she has actually had a lymphopenia. CRP was negative, cultures were no growth, serum ferritin was more than 10,000. Triglyceride fibrinogen were not much elevated. The HRCT chest was done and along with the USG abdomen was normal. The CMV PCR, the second test which was done a week apart, was showing an increased number of copies, which were 90, I think from 37,000 to it became to 97,500. It was during the COVID time, so RT-PCR for SARS-CoV-2 was done, which was negative for twice. And we planned a CT brain and nasal endoscopy based on her clinical examination findings. Before going to the CT, what differential I had considered after the clinical examination were, one, it could be a ganciclovir resistant CMV infection. So ganciclovir resistance is quite common in the patients who are on an antiviral prophylaxis. Second is a post-transplant HLH, which is also a known entity because her ferritin is quite high. And third was an invasive fungal infection because her sinuses, oral cavity, and face seemed to be involved on clinical examination. So this was her MRI scan of brain and orbit, which is showing altered signal intensity involving right frontal, ethmoidal, bilateral maxillary, posterior ethmoidal, and sphenoid sinuses. On CT, there is a thinning and dehiscence of medial wall of the bilateral maxillary sinuses. If you can see this highlighted lines, which shows that post-contrast, there was a lack of enhancement. So maxilla, hard palate, all those were not enhancing. So this is called as a black turbinate sign, which is actually favoring an invasive fungal infection. So absent sinus mucosal enhancement suggests a necrosis. So with this, we involved a ENT surgeon for oral cavity exploration and also for the diagnostic nasal endoscopy, because the suspicion of fungal infection was very high. The biopsy from the oral cavity samples showed a gram-negative bacilli, which further was identified as the E. coli. Based on radiological findings, we thought it's a probable case of mucormycosis, and without wasting time, we started the patient on amphotericin B and deferasirox, and later on added a posaconazole also. The nasal biopsy on endoscopy showed fungus and confirmed it to be a mucor. So this is a picture, picture of the slide which from the nasal biopsy, where you can see I have put a marker over here. These are the broad non-septate ribbon-like things here, so which have 45-degree branching. So this is very, very typical of mucormycosis. Nowadays, mucormycosis, we see COVID associated, we have seen a diabetes associated, we have seen a transplant associated, even flu associated mucormycosis is very known. So in case of a mucormycosis, diagnosis is often delayed. We are fooled around some non-specific symptoms. Like in this patient, it was just fever. And disease tends to progress very rapidly. It is actually a medical as well as a surgical emergency. Why? Because it's the golden window period in the mucormycosis is just early 6 days. So if we do not begin the treatment within first 6 days of the symptoms, then the mortality increases from 30 to 40% to 60 to 80%. So a difference of few days will make a patient almost, the disease will be uncurable. Fluconazole prophylaxis. So actually, whenever the patients are on a fluconazole prophylaxis, the other yeast and everything will be inhibited, but the molds like mucor are not inhibited. So they become actually prone for the mucor. But that is not a contraindication for fluconazole prophylaxis, because there are many other fungal infections which are prevented. So high-risk patients, we start on patients on a fluconazole prophylaxis. The duration of the therapy in case of mucor is not standardized. So till what time do we give injectable amphotericin B, or till what time we give posaconazole is not standardized. It depends upon the clinical response of the patient. So in general, 4 to 6 weeks to some months, 3 to 6 months of therapy is given depending upon the clinical response. The immunological defect which has made the patient prone for mucormycosis has to be resolved. So in case of diabetes, the sugar levels has to be strictly controlled. If the patient is neutropenic, we start GCSF. If the patient is on immunosuppressant, we try and decrease the dose or stop if possible. So that is very important for overall treatment. Some adjuvant therapies have been promoted, or there are few studies also which says that they are useful, but we are not sure whether they make a difference. But deferasirox and atorvastatin are such two adjuvant therapies, but they are not primary and never used as a single agent. They are always used in adjunction with the antifungal agent. So this was an aplastic anemia girl with the mucormycosis. I would go to my third case. It was a 14-year-old boy who was undergoing therapy for ALL, had a fever, had a visible swelling on the maxillary region on the right side of the face. He presented with cough and expectoration. He was very sick looking clinically and had a painful swelling, was not allowing to touch his face. The CT sinus was planned with the high suspicion of mucorrhea. This was a CT where you can see a mass filling his sinus, completely obliterating. So considering this, debridement was done, tissue was sent for histopath. The histopath suggested that there is a necrosed material, but there is no fungus or there is no angioinvasion, which confirms a diagnosis of mucor. But still, because of this picture, we started him on amphotericin B. He was already started by a hematologist empirically because there was a neutropenia, sinus involvement, and radiology favoring mucor. Patient kept on deteriorating despite on amphotericin B. Source control was done, the exploration of sinuses was done, and it rapidly spread to the left maxilla now, and the fever was persistent. So what were the differential? Rhinosporidiosis. It also present like this with the rhinocerebral sinus involvement. Second is mucor. Third is invasive sinus aspergillosis. Fourth is a sinonasal polyposis, that he must be having a polyp sitting over there since beginning before the diagnosis of ALL was made. This was a CT chest. So child also complained of cough intermittently. So we planned a CT chest and it was showing a cavity in the superior segment of the left lower lobe. Now to join these dots, he has a sinus involvement, also has a lung involvement. So if I have to fit into an invasive fungal infection with sinus and lung both involving, it favors an aspergillosis. Diagnosis of aspergillosis can be achieved by this serological biomarker, which is known as an aspergillus galactomannan levels. So we did a galactomannan levels both from serum as well as a mini ball. The serum galactomannan level was 1 and the ball galactomannan levels were 2. So the diagnosis of sino-invasive and pulmonary aspergillosis was established. If I have to elaborate on these galactomannan levels, they have a lot of positive, false positive value. So to decrease the false positive value, we take a cutoff a little higher. So if for a ball galactomannan level, the cutoff is 0.5. Anything less than 0.5 is negative, anything more than 0.5 is positive. But if we want to be very sure and decrease the false positive, we take this cutoff to 1 or 2. If the levels are a borderline, we try to do 2 tests, so that the increased number of tests and higher cutoff will reduce our false positive value. So diagnosis was established. We started this child on voriconazole. This is the growth of aspergillus. Sometimes the aspergillus niger. So there are aspergillus flavors, fumigatus niger. These are the species of aspergillus. But if the aspergillus niger is the species, causative species, the culture on the seborrheic dextrose agar showed early growth, which was pigmented like this. So actually this growth mimics the growth of a mucor. So it can be sometimes confusing. It will mimic a mucor. We will think it's a mucor. But if we give an anti-mucor treatment, which is amphotericin B, child will not improve. So this was actually later, we found that this is a pigment producing aspergillus niger. We started him on voriconazole and then shifted to orally, and which the treatment continued for almost 6 months. These are the very beautiful microbiological pictures where you can see the aspergillus. This is a lactophenol cotton blue staining where culture will show you the growth of this branching hyphae, and very nicely seen a conidiospore. They are like a bunch of flowers or something. So this is on a low power microscopy. This is on a high power microscopy. Yeah, the same one, the conidiophore, the septate hyphae. And so this was invasive aspergillosis. Moving to the fourth case, 13-year-old boy who presented with fever, headache, vomiting, treated as a query-enteric query PUO, was treated with injectable ceftriaxone. And they took a DAMA after 5th or 6th day of injectable therapy, were discharged on an oral cefixime, and they readmitted within a 1 day with the generalized tonic-clonic seizures. As the signs of meningitis were there, the patient was empirically started on IV meropenem and vancomycin. Fundus was done, and which was suggestive of early papilledema. MRI was done, which showed a diffuse leptomeningeal enhancement, ischemic foci in the bilateral frontal deep white matter. The CFX examination also confirmed the clinical diagnosis of infective meningitis. Fundus was suggestive of raised ICT. And surprisingly, we got a culture report saying that it is growing a Cryptococcus neoformans. So where the MIC of fluconazole was 2, which is sensitive. CSF CBNAT was done having suspicion of a tuberculosis, which was negative. And after this report, pediatrician started the patient on IV fluconazole. The therapy was later on upgraded to IV liposomal amphotericin B because patient was not responding. Repeated fundus were done on day 8, 13, 19, which showed no improvement. And the retrospectively inquired about travel history, which was negative. And these are all the CSF reports. If you can see, the cells range from 50 to 120 max, and they never improved to become normal throughout the therapy. If you see protein also, it kept on from 44 to 100 in this age, in this range only. The Cryptococcus was positive on the day 1, and later on day 42, even the MSSA was cultured from the CSF. So at this point of time, the child was referred to me. So actually the treatment for Cryptococcus is divided into an induction phase, consolidation phase, and a maintenance phase. So in the induction phase, we give a amphotericin B 5 mg per kg along with the flucytosine. So we started this child on flucytosis 100 mg per kg divided into 4 doses. After 2 weeks, we discharged the child with the starting a plan of consolidation phase. So consolidation phase was high dose fluconazole, which was 12 mg per kg. With this plan, we sent a child home. We also did a workup for immunodeficiency because cryptococcal meningitis is most commonly seen in a HIV positive patients and usually not seen in an immunocompetent patient. But this was a normal grown child, healthy boy with no previous hospitalization, nothing, well grown. HIV was done, which was negative. CD4 counts were normal. Absolute count was 1012. The field of vision and refraction was severely affected on discharge because of the delayed diagnosis. The raised ICT had called already optic nerve damage. So patient was counseled for the high risk for the development of the optic atrophy in future. Patient got readmitted in few days with the headache and deteriorating vision. So this was his neuroimaging. If you can see this small pearl-like things all scattered throughout the brain matter. Yeah. So these are nothing but the cryptococcomas. So this is a very rare complication where the discrete encapsulated lesions of immune infiltrates and pathogen forms. It's like an iris. It's an immune reconstitution inflammatory syndrome. So whenever we initiate a treatment targeting something, the patient overall general immunity gets elevated, and there is a phenomenon where they target the bug again with the improved immunity, and then there will be a apparently deterioration of the primary disease. It's not an apparently deterioration, it's a paradoxical exaggerated host response. So it's very common in the immunocompetent patients and Cryptococcus gattii infection. So I remember we had one child of Cryptococcus gattii who had traveled to Ooty. He had a history of going to Ooty by some school trip or something. And after coming from there, a week later, he kept on complaining of chest pain, chest pain, chest pain. There was no fever, nothing. We got an X-ray done. There was a big lobar pneumonia. Later on, we did a bronchoscopy and found it to be a Cryptococcus gattii. And then we correlated it with that because of the eucalyptus trees in the Ooty. The child must have got the Cryptococcus gattii from the eucalyptus trees. So somehow I told you the geographical history helps us. So this child, again, we treated with the antifungal therapy, and we gave us steroids for iris management. 5-flucytosine was added. And this infection was actually an apparently immunocompetent child, which we do not see very commonly. My last case, 7-year-old boy admitted with fever for 10 days, generalized weakness, fatigability. This child is still admitted with us, diagnosed with B-cell ALL. Count 530 was his total WBC count, 12,000 was a platelet count, and neutrophils were just 2%. So ANC was just 10. IV hydration and steroids were started. And at the site of IV cannula, after removal, there was an observation of a small bleb formation. So at the site of thrombophlebitis, the child was already on an empirical antibiotic coverage, such a low count, and this blackish discoloration was progressing. So if you can see that this was the central bleb which was visible first, and this blackish discoloration with the surrounding edema is observed. So we thought if it's a progressive, it's mostly is an ichthyoma gangrenosum. So antibiotics were upgraded. Anyways, the child was severely neutropenic. They were upgraded to meropenem and vancomycin in view of a severe neutropenia. The lesion progressed to involve the surrounding skin, subacute, causing edema, and exudate. So this was a picture. Next day, very next day, within 24 hours, the lesion progressed like this. So this time, the peripheral areas, the skin subcutaneous tissue was severely involved. There was edema, erythema, the fluid which was exudating, and the central was a Ishar-like thing which has formed. And this ulceration has a ragged margin. Patient continued to deteriorate despite our antibiotics. So the swab was sent for, or from the exudates was sent for bacterial culture, suspecting then MDR polymicrobial infection. First, we thought ichthyoma gangrenosum, which is caused by Pseudomonas very commonly. But because the child was not responding, we thought it's some multi-drug resistant polymicrobial infection, which is causing such a fast spreading cellulitis-like thing. Lesion still progressed further. We planned a debridement by a surgeon to remove all the dead tissue, and we sent the scrapings from the wound margin for the bacterial culture. Also, the child complained of a cough with the background fever, so HRCT chest was done. So this is the picture before debridement, the first one, and after debridement, this is. So the tissue was not easily debridable. They just removed the dead and loosened tissue, but the rest, hardened, blackened margins were left like that only. The CT scan of the chest showed that there is a right middle lobe, wedge-like areas of necrosis. So this is a CT picture. It's easily appreciable, and it's looking like an infective consolidation. But this cut favors a little bit of a halo sign, if you can see a wedge shaped with the nodular. So this was a microbiological report from which was sent from the swab. It showed a growth of rhizopus. So this was in rhizopus causing cutaneous mucormycosis, a primary cutaneous mucormycosis, which is a very rare variety. So in mucormycosis, the most common is a rhinocerebral. The next common is a pulmonary. The next common is cutaneous and a GI mucormycosis. So we started to reduce his suppression which is offered by the steroids. We started him on an injection GCSF to improve his immunity. Amphotericin B with oral posaconazole was started. Aggressive deep debridement, we had to convince surgeon that this will need a really deep debridement to be very aggressive. Otherwise, we will not be able to achieve the clinical improvements. Neutrophil count improved within 5 days of antifungal. We started with the vincristine, and later when the child became febrile, we gave him a proper chemotherapy. The X-ray limb was done to rule out a bone invasion. This is the X-ray, which was not suggestive of any bone invasion. So cutaneous mucormycosis usually presents as a fast-spreading gangrene. Asepsis is very important in care of IV cannula. We have seen multiple infections related to IV cannula, especially in those the children who are given daycare therapies and sent home. This is very common problem. Prevention in the ICUs is by only following the bundle protocols, which are for the nosocomial infections. Source control is very, very important in invasive fungal infections as in other infectious etiologies. And antifungal agents are really life-saving when used in time. So that happened with our child also. He's been saved. But there are a lot of controversies in medical mycologies which are not clear. So I'm going to list upon few controversies which we are facing is that when to use the antifungal prophylaxis, in what categories should, in this child when the ANC was 10, we would have started antifungal prophylaxis from the beginning. So there is a data which says that the all cause mortality with the antifungal prophylaxis is reduced in stem cell recipients and high risk leukemic patients. So we should have started with antifungal prophylaxis to begin with. The role of biomarkers, as I already said, that 2 consecutive positive tests will exclude the false positive, and we should use a higher cutoff to prevent the false positive. The combination therapy. So combination therapy has been useful in cryptococcosis and aspergillosis, but in others we are not sure whether we should combine the other antifungal agents if there is no clinical response. Echinocandins as a first line therapy in sick children or neutropenic children, because nowadays we are finding more and more candida species like Candida aureus and others which are coming as an amphotericin B resistant. So whether when the children are very sick, we don't want to take a chance and we don't have a time to buy, should we use a caspofungin as a first line of agent and then step down after the culture reports? We are not sure. And the non-culture based diagnostic tests. So we are in a very bad need of some diagnostics tests which are very easily available, affordable, and which gives us a fast results. There are few tests which are in a pipeline, are a lateral flow assay and a cell-free DNA detection, which will give us a very good results without any false positive and false negative test. So we hope we are able to make the diagnosis of fungal infection in time. So that's it. In my case, I'm open for the questions. Thank you so much for the patient listening.
Yeah, thank you so much, Dr. Kamna. Really very interesting cases that you have gone through, and it's always a pleasure to learn from cases rather than just talking about theoretical aspects. So it was very good. As a general pediatrician, my question is that how much does this matter to me?
Yes, sir. So if I go to the last case, sir, the one which came with the ulcer, this case was referred to us from a general pediatrician only. The child was admitted with him with the fever of 2 days. The IV hydration and ceftriaxone was going on. They referred the child to us with the IV cannula in C2 only.
Right.
That was removed and we followed. So whenever you also have a, like suppose any general pediatrician also have a patient, we usually do the counts. If
Right.
there is such a severe neutropenia, the fungal infections to be kept
So
in mind.
suspected. Okay.
Yes, sir. Even a candida, like many general pediatrician treat with the higher antibiotics like vancomycin and meropenem. TJ cycline is very rampantly used when there is a non-responding community acquired infection, thinking that it's a broad spectrum antibiotic and it will cover all the infections. So even a TJ cycline use and even higher antibiotic use more than 7 days makes them prone for the candidemia. I think that has to be kept in mind because now we are seeing rise in number of candidemias as compared to before.
It's a very good message for all of us. Any other comments from other physicians who are in the group?
I think physicians see a lot more of a fungal infections than what
Hemant wants to make a comment.
Hello.
Hello, sir. Hello, sir.
Arif, yes, Dr. Arif is from Hyderabad, he's an allergic specialist. Yeah. So Arif, first your comment and then Dr. Hemant's comment. Yes, Arif.
So no comments, only questions.
Okay,
because you are an ID specialist and the topic is about fungus and I'm an allergist. See,
Yes,
I
sir.
see a lot of children coming to me with fungal skin infections because they think everything that itches is an allergy, which in fact it is nothing but a fungus infection many of the time. So in
Correct.
pediatric now, there's an epidemic of fungal skin infections going on. Can you hear me? Yeah.
Yes, sir.
So what is the drug? And many of them, they come with recurrent fungal skin infections. How would you manage these cases with recurrent?
So, skin infections, sir, right?
Yeah.
Okay, so that's a non-invasive function,
Yes,
fungal infection. And most of the time, the tropical antifungal agents are good enough for the fungal. Those who have a recurrent infection, severe, not responding to the tropical agents, you may give oral antifungal also. So previously we used to only use cotramaxazole for as an ointment which is available. Nowadays there is a luliconazole, which is a better azole available as a local therapy for them. If there are recurrent infections, sir, we should also look at their CBC. Sometimes we have a recurrent oral candidiasis or oral thrush as a presentation in a primary immunodeficiency also, sir.
No, this is a tinea infection with the adults in the family are having it. Okay, and
Right.
since the adults also have got it, these people, the adults, we are putting on itraconazole. What about the pediatrics? I mean, the
Even
topical are
for
not
the
possible.
oral. So in pediatric,
which
we
to-
first try tropical, sir. First we try tropical. If it's not responding tropical, we do give itraconazole even in pediatric age groups, sir. About 2 years.
So would you recommend the pediatric age group? It is only available as 100 mg and 200 mg. So,
I
and
would
how
check the dose, sir. I am not.
and which lower age group would you go for itraconazole? Is there the age group for that? for
About 2
itraconazole?
years, sir. About 2 years we give itraconazole.
About 2 years. Okay, but we don't have in the syrup formulation. We have only in the tablet formulation,
Yes, sir.
itraconazole.
Yes, sir.
So that is the because there are no syrups, right?
No, sir. No syrups are available. Even for the voriconazole, no syrup is available. Posaconazole is available as a tablet only.
So, but
So
you
we
say
pulverize
itraconazole
them.
is safe in pediatric age group.
Sorry, sir.
Itraconazole is safe in the pediatric age group, and for how
Yes, sir.
long should it be given? Would you
That depends
recommend?
upon the site, sir. That depends upon the
Okay.
site of the infection, whether nails are involved, not involved. So usually
Then
3
usually the
months.
nails, usually they have the face, the fungal infection on the face or in the maybe in the axilla and all. These are the common ones which you are seeing in the pediatric age group, tinea infections.
Correct. So in those patients, sir, 6 to 8 weeks is more than enough.
Okay. All right. Thank you, Dr. Gandhi.
Yes, sir. Yes, sir.
Now, there is one question in the chat box, and that is from Dr. Kiran Saha, physician. The 2 consecutive tests at what time of intervals should be done?
Yes, sir. So no interval actually, sir. Like if I have a patient who is in ICU and whom I'm suspecting to have a infection with the candida or say aspergillus, then you can do a test on consecutive days also. So today I have sent one test and tomorrow also I can send another test. So it's not for a rising titer or so. It's just to decrease the false positivity because of some other factors. Which can give rise to maybe a colonization, environmental contamination, all those. So 2 consecutive tests can be even sent on same day or the next day also.
Okay. Now, Dr. Hemant Sant and Dr. Manoj Yadav later on. Yes, Dr. Hemant.
Very nice presentation of a very complicated topic, because as an adult treating physician and a part of critical care, we know that antifungals are one of the most toxic, most drug interactive oral drugs also. And in ICU also, lot of infections are missed. So my question is, message from you experts should be how to diagnose fungal, how to suspect and confirm diagnose fungal infections early, and how to monitor the treatment. You have already elaborated in 5 cases,
Yes,
but
sir.
the message should go home.
So the most, I think, most effective method is we always send the cultures. So whenever you are treating patients in the ICU, you are using lot of antibiotics. Whenever you change or upgrade the antibiotic, please send a blood culture. So candidemia is the most common invasive fungal infections in the ICU, and they are easily grow on a blood culture. So send cultures, form and habit of sending culture whenever there is a change in the antibiotic. Second is we can always give a prophylactic antifungal, especially in the critical patients. If the patients are critical, admitted, ventilated, have a neutropenia, start with antifungal treatment. If we do not grow any candida, the patient has become better, you can always step down and stop it. But whenever there is a high clinical suspicion, give antifungal, especially those who have a central lines, spiking fever, have a low leukocyte count. we give a prophylactic antifungal therapy. Monitoring of the therapy is best by the, like in case of a candidemia, if I say, it's best by the blood culture. So we repeat blood culture every third or fifth day to find out when the candidemia has been cleared. So actually to decide the duration of the therapy, because in candidemia, whatever antifungal you are using, may it be a fluconazole, amphotericin B or caspofungin, it should be continued for 2 weeks after the blood culture has been cleared off. So
What special care is taken for culture? Which medium today? Liquid medium is used and directly venous blood is drained into the medium.
yeah, so nowadays
Because
all
the way
cultures
the
are
culture,
bacterial. Nowadays, sir, all cultures are bacteric cultures. We get a Vitek sensitivity report, and Vitek will detect Candida very well. So there is no special medium. We can send a fungal culture, especially in case where we know that this is known case of fungal this thing, like how we know in a aspergillosis that we are suspecting a sinus involvement is there. In that, I will send that tissue in a fungal medium. But when the patient is in the ICU, the same blood culture which you are sending for bacterial nosocomial infection will detect a fungal infection. So only in cases of tissues, you need to send it in the fungal medium. Otherwise, the blood cultures will detect the fungus. Only I'm talking about Candida. Aspergillus, mucor, rhizopus, they all will be diagnosed more on a histopath and staining.
tissue.
Correct.
We surgeons always send tissue in diabetic food also.
Correct. Yes, sir. Yes, sir.
Dr. Manoj Yadav.
Yeah, good morning.
Good morning.
Really good cases. And I'd like to ask you that where do you place itraconazole in versus voriconazole when managing patients with aspergillus? Because the cost factor is quite huge when we treat patients of aspergillus with
Correct.
voriconazole.
So we do
what is-
not use itraconazole. Voriconazole has been proved to be of a very higher efficacy for aspergillosis. So voriconazole is a drug of the choice. Itraconazole can be used if the financial problem is there in a later when the aspergillosis has been treated well and a patient is on a maintenance therapy, say after 8 weeks or so, but not in the beginning. I have never used itraconazole in a sick patient with the active aspergillosis. It can be given even for the prophylaxis. I have never used itraconazole, and I don't think none of the guidelines like International Fungal Network guidelines suggest itraconazole can be used. It can be, I think, practically taken as an alternative by Indian physicians, but I doubt the efficacy for prophylaxis also, because all the post-transplant patients whom we give prophylaxis with, for whom we have a galactomannan positive later on also are on a prophylaxis for a long time. So those also we give a voriconazole only, sir.
Okay. Now, personally, I have used voriconazole in patients who are not affording voriconazole. Itraconazole I've used.
Okay.
And
Okay.
a little dose. And there are case studies. Unfortunately, in the guidelines is not there, but there
Correct.
are. And I used successfully.
Okay. Great.
And the cost
I
because of
have never used, sir. I have never used.
Okay. Thank you once again for the good luck.
Thank you.
Good interaction. Kamna, I have one question that when we talk about using antifungals as prophylaxis
Yes,
in
sir.
ICU settings, now when we talk about antibiotics, now we fear about resistance. So
True.
do we have that fear with antifungals also?
Yes, sir. Yes, sir. Fluconazole resistance has increased so much, but sir, especially in neonates, if I say, we have a neonates who are with us, say premature babies or very low birth weight for weeks together in the NICUs. They receive most of the time the empirical and preemptive antibiotic therapy. Whenever the weight is less than 1.5 kgs, whenever the child is on antibiotics for more than a week or so, it's advisable to give a antifungal prophylaxis with fluconazole, which is twice a week. It's not an everyday. So it's a twice a week antifungal therapy. And once the neutropenia is not there, or the baby has grown to say a critical point of 2.2 kgs of birth weight, just stop it, sir. But it has been studied and proved that the antifungal prophylaxis will reduce the incidence of candidiasis in the newborns. So
Okay, but we
fungal
should use it.
fluconazole resistance is there, sir. Now we are seeing the fluconazole resistance, but the benefit ratio with the prophylaxis is proved, no doubt.
Right. So we should use it judiciously as per guidelines.
Yes, sir.
You said
Yes.
the culture yield is only 50% usually?
Yes, sir.
Okay.
It's only 50%.
Right.
That's why there is more and more research going on these biomarkers. Like now we have this 1,3-beta-glucan and galactomannan, but very erratic results. If I do
And
in
again, you said there are a lot of false positives there.
lot of false positives, a lot of false negative, so I think the cell-free DNA, which is which is very accurate and which will give us very good results. So Mycology is very much excited about the cell-free DNA. If it comes into practice, it will help us to treat the fungal infection in a very different way.
Do we have multiplex PCR for fungal infection?
It's there, sir, but we don't know whether clinically they will be relevant. Because we will detect the gene, but we are not sure whether it's a colonizer, it's causing infection. Same with the bacterial biofires which are available. In fact, they are more confusing in case of a fungal genetics is concerned.
Good. So thank you so much, Dr. Kamna. It was really a wonderful presentation, and the post-presentation interaction was also very useful. So thank you all for participating. We meet next Saturday again. So thank you all. We end the session here. Thank you.
I want to thank you, sir, for giving me a